Welcome back, everyone. We've got a truly fascinating one for you today. An explainer that completely challenges decades of established medical practice. Okay, let's dive into this. We're going to unravel a massive medical mystery surrounding one of our oldest, most trusted tools, penicillin. Specifically, we'll be looking at exactly how long we actually need to treat severe childhood pneumonia, and how modern clinical trials are literally flipping our traditional prescribing habits totally upside down.
Here's our quick roadmap for today. We'll start with the Penicillin Paradox, then move into questioning the status quo. From there, we'll break down the groundbreaking Pedicap trial, look at why shorter is just as good, and finally wrap up with a concept called finding the floor.
All right, part 1, the Penicillin Paradox. Let's set the stage.
Now, what's really interesting about this is how it exposes the surprising foundation of our current medical guidelines. It turns out some of our most rigid medical rules aren't actually built on hard science. Think back to the 1940s. When penicillin first hit hospital wards, doctors were basically just learning on the fly. And because the drug was incredibly scarce, they had to treat even severe pneumococcal pneumonia for just a few days, using much lower doses than we use today. But guess what? It worked. The treatments were actually super successful. Fast forward to the late 20th century, though, and drugs became widely available. Clinicians slowly drifted away from those short, successful courses and started prescribing longer and longer therapies, mostly because textbooks just started saying so. But today, we're finally seeing a huge wave of clinical trials questioning that long-course habit.
Which brings us to a kind of uncomfortable truth in the medical community. For decades, the creeping increase in how long we prescribe antibiotics wasn't actually driven by robust clinical evidence. Nope. It was driven by institutional habit. We just got used to prescribing longer courses, it got standardized in the textbooks, and we just kept doing it, assuming, more must be better. But as any good scientist knows, habit is absolutely not a substitute for data.
That takes us to part 2, questioning the status quo.
Thankfully, we're entering a modern era of medicine where we're finally taking a hard look at these entrenched, drawn-out therapies, which leads us right to this core mystery. How long must we actually treat severe childhood pneumonia? It is genuinely mind-boggling when you stop and think about it. We've had penicillin for over 80 years. It's literally one of the most studied drugs in human history. And yet this fundamental question, exactly how many days a kid needs to be on antibiotics to safely cure severe pneumonia, has completely confounded us. Let's compare the old-school mindset with what modern researchers are asking today. For a long time, the World Health Organization's older guidelines drew a hard line. If a child had severe pneumonia, the absolute rule was they needed at least 5 days of IV therapy in the hospital. But in 2014, the WHO actually updated the very definition of severe pneumonia. And that prompted researchers to ask a really bold new question. Could kids meeting this new definition safely step down to just regular oral antibiotics after only 1 or 2 days of IV treatment? Just 1 or 2 days. Imagine what a game changer that would be.
That brings us to Section 3, the Pedicap trial. The ambitious attempt to finally get some answers.
To tackle a question this big, researchers needed a massive, meticulously designed study. Enter the Pedicap study, recently published in The Lancet by Julia A. Bilecki and her colleagues. This was a landmark piece of research. We're talking about an ambitious 2x5 factorial randomized controlled trial involving over 1,100 kids ranging from 2 months to 6 years old. These were children hospitalized with severe pneumonia across sub-Saharan Africa. And to make sure the data was rock solid, the researchers used C-reactive protein testing to specifically confirm bacterial infections in their sample. So this wasn't some tiny observational study. This was highly controlled, incredibly robust science.
And this brilliantly illustrates their clear two-step methodology. They wanted to test shifting patients from heavy, hospital-bound IV medications to simple oral pills or liquids. So, step 1, all the children started out receiving the standard WHO-recommended IV antibiotics. Then, for step 2, they were randomly assigned to step down to oral medications, specifically either standard amoxicillin or the much heavier co-amoxiclav. Let's look closely at how they structured this, because it's pretty clever. They split the kids up. The control group continued on IV-only therapy for the standard 5 days, but the experimental groups, they stepped down to oral medications for total treatment durations of either 4, 5, 6, 7, or 8 days. By doing it this way, the researchers could test the route of the medication, IV versus oral, the specific drug used, and the total duration, all at the exact same time. The ultimate goal was to see if these shorter oral step-down treatments were just as good as the traditional heavy IV courses.
Which leads us perfectly into Section 4. Shorter is just as good. Get ready for some incredible findings.
Okay, here is the absolute aha moment of the entire study. When they compared the kids who stepped down to oral meds for anywhere from 4 to 8 total days against the kids who stayed on IVs for 5 days, there was literally zero difference in the primary outcomes. No difference in 28-day hospital readmissions, and no difference in mortality. None. Stepping down to oral antibiotics for shorter durations worked exactly as well as staying on IV medications. And, as a huge bonus, plain old amoxicillin proved to be just as effective as the heavier co-amoxiclav.
But beyond just clinical efficacy, we really have to look at the real-world human impact here. Getting oral medication was associated with significantly shorter hospital stays. Kids on the oral step-down treatments went home in about 5.2 to 5.5 days, compared to 6.5 days for the IV-only group. That is a full day earlier. And, in low and middle-income settings, getting a severely ill child healthy and out of the hospital a day sooner, that drastically reduces the amount of time an entire family has to put their lives and their livelihoods completely on hold at a hospital bedside.
So the crucial point is this specific number, plus 0.9%. Because there's a slightly darker side to longer antibiotic courses. The Penicillin trial found that for every single extra day a child was kept on oral antibiotics, their risk of antibiotic-associated adverse effects increased by nearly 1% per day. Think about that. Longer courses don't just fail to give any extra clinical benefit. They actually increase the likelihood of side effects, actively harming the patient's GI tract and overall comfort.
And that takes us to our final section, Section 5, Finding the Floor.
In medical research, there's this really interesting concept known as finding the floor. It basically means mapping out a treatment to identify the absolute shortest duration you can prescribe a drug while still maintaining maximum clinical efficacy. You want to find that exact tipping point where going any shorter causes the treatment to fail. But here is the wildest part about the Penicillin trial. They technically failed to find the floor. They went as low as they dared, just 4 days of total therapy, and it was still highly effective. It worked just as well as any other duration they tested. They went looking for the floor and couldn't even find the basement.
Which leaves us with this super clear, actionable takeaway. The hard data shows that just 1 or 2 days of IV penicillin, followed by a short oral course of standard amoxicillin, is highly effective for treating severe childhood pneumonia. This shorter course is clinically proven. It gets kids out of the hospital faster, and it spares tiny gastrointestinal tracts from unnecessary prolonged exposure to harsh antibiotics. It's a win all around.
Jason C. Gallagher, the author of the Lancet commentary on this trial, perfectly sums up the excitement in the medical field right now. He asks, how much shorter can we go? Multiple signals suggest we have not found the floor. And guys, this isn't just happening in pediatrics. Gallagher notes that adult trials for community-acquired pneumonia have found the exact same thing. A mere 3 days of therapy is just as effective as 8 days. We are witnessing a massive, broader medical shift away from the long-course habits of the 20th century.
So, I want to leave you with this final provocative thought. We've seen the data. We know that scarcity back in the 1940s forced short, successful courses, and that simple habit later artificially inflated those durations. Today, rigorous trials like Penicillin prove beyond a shadow of a doubt that when it comes to antibiotics for severe pneumonia, less is often more. So if shorter is clinically just as good, and longer only adds harmful side effects, how much longer will we let habit dictate medicine? Thank you so much for joining me on this data-driven journey today. Keep questioning the status quo, and I'll see you in the next explainer.